discuss this topic with you. And we are live.
Yes, the feelings are mutual. I mean, I've watched a lot from the Nutrition Network and some of the awesome work y'all are doing and you've done. So very excited to be a part of it.
Well, thank you, Dr. Buchanan. We were saying, audience, welcome. I just want to say welcome. Me and Dr. Buchanan were saying how, this is well overdue, our discussion and our affiliation, and we couldn't be happier, to have Dr. Buchanan here talking about such an important topic, which is women's health, but specifically in menopause, because we're all going to get there, or we've all been there, or we all are there. I mean, as a woman, there's no avoiding it other than, dying. So we've all got to actually know about this and the horror stories that are out there from women who have been through it, some of whom it's been a really, really horrible experience. And it seems like, I'm working my way through the lectures at the moment in the training that's launching at the end of this month. And I'm learning so much about how all of those terrible things, or many of those terrible things, can be avoided. So I think this is so timely and timeless, and such an important topic. And I can't wait to rack your brain on it, Dr. Buchanan.
Thank you. Well, I totally agree with you. I'm thrilled to discuss it because I really didn't get much education on this, hardly at all, in residency. And wow. I had to kind of seek, I had one lecture, and women spend often more than 40% of their lives post-menopause. And so to have one lecture on, this huge topic is pretty crazy. So I had to go do my own research and learning and get additional certifications to learn more about this topic. And it has now been a really fulfilling part of my practice to be able to help women through the menopause transition.
Yeah. Well, I mean, that actually sounds unethical, right? To only have that one day of training on it when, as you say, you spend as a woman 40% of your life in this phase. It really is unethical. And the fact that I think there are more women than men in the United States, at the very least, probably over the globe. And women have been so under-researched, as, Dr. Madison Cackley explains during her lecture. So it's all wrong. It's all topsy-turvy. And I think one of the taboo subjects, Dr. Buchanan, is sex, right? Mm-hmm. People barely talk about sex when, they're in their, most sexually active years, let alone during menopause. And the older you get, it's almost like, okay, well, those people don't have sex anymore. Let's not talk about that. It's all taboo. And it's all like, it's not really accepted. But yet, if you're spending that much of your life in menopause, plus, many women who are in that phase, they've got partners, they're married, or they want to still be sexually active, or their partners still want to be sexually active, and they want it to be a wonderful experience, not a painful, horrible experience. Yeah. And so that's what we're really going to be talking about today, how to optimize sexual wellness in this phase of life, which I think everybody wants to hear about. So thank you so much for joining us and being willing to talk on this topic, on this very hot topic, but also very taboo topic. Thank you.
Yeah. Thank you for hosting it.
Awesome. So I'm just going to say a little bit about you. You've already said, that you had to do additional training in menopause. And I just want to tell everyone that Dr. Laura Buchanan is not only a board certified physician in family and obesity medicine and a certified metabolic health care practitioner, but she's also a certified practitioner within the Menopause Society in particular. Which reflects her work in this area. So we couldn't be speaking to more of an expert in this area on this topic, and a woman, which is really important. So together today, we're going to be exploring what happens to sexual health during menopause, practical solutions to challenges that many, if not every woman faces. And then we're going to just touch on the role that hormone replacement therapy has. Yes, risks versus benefits, but that's not really where we're going to be focusing. Again, it's going to be within the sexual health realm, within perimenopause and menopause. And for those of you who are very interested in the topic of menopause, which, as I said, all women really should be, and everyone who's got a woman in their life or a woman partner really should be interested in this topic. Nutrition Network's Perimenopause and Menopause course will be launching at the end of September. And if you sign up before the launch date, you get 30% off as an early bird special. So it's a really good idea to sign up now rather than later so that you get that special. So let's dive right in, Dr. Buchanan, and start breaking down the myths, the science, and giving the women the hope and the solutions that they actually deserve, right?
Yeah.
Okay. So I think can we start with, I think the first question that popped in my mind when I was thinking about this topic in preparation to discuss it with you is that many women and their partners are terrified that when the woman hits menopause, or even leading up to menopause in that perimenopausal phase, which is the phase leading up to menopause, they're terrified that at that point menopause hits and their sex life is just going to be over, just like that. And I think that's a very it permeates everything, that kind of idea, even though no one really talks about it openly. Are those fears well-founded? And if so, where do they come from?
Yeah, I would say they are not well-founded. They arise in part because there is silence around the topic, because again, like you said, it's kind of taboo. There's stigma. There's also a lack of education. Again, I just mentioned I had one lecture in residency, and we really did not discuss sexual health during that lecture. It was more about systemic hormone therapy, not about sexual wellness or well-being in women. And so there's just a lack of education for providers, which then means patients themselves or women, maybe they're looking online, but they're not finding answers, or maybe it's, again, they don't want to search that topic online. And so I think there's not really truth behind that the sexual well-being has to end at menopause. There are sexual health changes that occur with menopause, but most of the problems, or maybe all actually, are modifiable, and they can improve with a mix of local therapy, which could be hormone, it could be non-hormonal, pelvic floor health, which I'm sure we'll talk about later, and then also just supporting relationship and mental health during that time, which mental health, for a variety of reasons, can sometimes have a toll, again, during that transitional period and even post-menopause. But I want to give people hope up front. I have worked with patients in their 60s who have not been sexually active for a decade because of differing menopausal symptoms, and we'll talk about genitourinary syndrome of menopause. And we've got them on a treatment plan, and they are thrilled to be back and enjoying sexual activity with their partner, even though it had been at some point almost 10 years.
Wow. Well, if that's not a message of hope, then I don't know what is. That's really awesome. Maybe you can tell us what is going on. So it does sound like, okay, so a lot of people, when they go through menopause, they experience maybe this 10-year dry spell potentially if they don't get the help they need. What is going on during that time? What happens in menopause to make sex so unpleasant and uncomfortable from a biological, physiological perspective?
Yeah, so there's many changes. The biggest thing that is happening is the fall in hormone levels. So during perimenopause, you have actually very large fluctuations, not only drops in hormones, but very large fluctuations in estradiol. So estrogen levels are going very high, then they crash, and then eventually, by the end of late peri and into postmenopause, your estrogen levels just stay low consistently. And so that drop in estrogen leads our vaginal tissue to become more thin, dry, less elastic. The pH in all that tissue actually goes up, which increases our risk for UTIs, yeast infections. You hear about women getting recurrent urinary tract infections, which can lead to incontinence, leads to recurrent antibiotic use, which leads to its own set of complications. And additionally, there's a lot less, sometimes no or minimal, lubrication or arousal that actually occurs from that drop in hormone level too. And so you can imagine if you have no lubrication, you have decreased arousal comfort. And even if a woman is able to orgasm, very often it is actually not as pleasurable when they do because of that drop in hormones. And so all of that is contributing to pain with intercourse, decreased desire. And you can very easily understand, hearing all of those different symptoms, that that's going to have a huge impact on quality of life, both for the woman, but also for their partner. And unfortunately, you can hear thinner, drier, but I mean, the pain that some women experience it's much more significant. I've had patients describe it to me as a tearing sensation, or feels like little daggers are poking them almost. And you can imagine, you love this person, you're trying to do something very intimate with them, and you're causing them that kind of pain during the activity. That's not healthy or good for anybody.
That sounds terrifying. It sounds absolutely terrifying is how it sounds. So I think let's maybe just jump right in there and say, okay, I know you mentioned other things. You mentioned the psychological, and we definitely want to go there. You mentioned pelvic floor exercises and, getting that right. We definitely want to go there. But I think now that you've mentioned all these terrifying, genitourinary symptoms related to that drop in hormones, or the flatlining eventually of hormones, what can women do about that? Do they need to be swallowing an estrogen pill, taking a patch? You've mentioned something about local hormones, which for everyone who doesn't know what that is, that's when you actually apply it at the spot that's relevant. So this might be, I imagine, vaginal, or I don't know, around there. Maybe you can tell us what are women supposed to do if they start experiencing these kind of symptoms?
Yeah, absolutely. And so again, these symptoms can occur even early in perimenopause. So even though you still have estrogen fluctuating quite a bit, even with the hormones present, you still may have these symptoms. So don't think it's only women who are postmenopausal that could derive benefit from local therapy or systemic hormone therapy. So if it's the main symptoms are truly just, there's vaginal irritation, pain, dryness, maybe recurrent urinary tract infections, then local estrogen, most commonly, especially for the UTI specifically, applied as a cream, not only to the internal inside of the vagina, but also externally around the urethra, because we have estrogen receptors all over the vulva, the urethra, the bladder.
Wow.
That can decrease risk of UTIs by over 50%. And
that's huge.
It is huge when you look at the potential financial, just from a monetary perspective. If you decreased, you could save anywhere from over $1,000 to $4,000 per year per woman who has recurrent UTIs, just from applying vaginal estrogen.
And not to mention how many women who have UTIs end up having to just dose it with that one dose antibiotic.
Yeah.
I find that that's so common, and you shouldn't be just taking antibiotics all the time. But many of these UTIs don't seem to resolve without an antibiotic. So, I mean, even if the cost aside, financial cost aside, the biological or health-related cost associated with having to continuously take antibiotics is also very, very costly to one's health.
Yeah, huge. And it's very sad. When I was in residency too, it was not uncommon to see women over the age of 65 who were coming in with urosepsis, meaning they were being admitted to the ICU, to the critical care unit, because they were septic from a urinary tract infection. And never did I see any one of those patients on vaginal estrogen. And at the time, I didn't know. We never even talked to them about prescribing it once we did help them get out of the ICU. But now, in hindsight, that would have been a great thing for us to be doing.
Yeah, and talking about pain, I mean, I just want to mention that for anyone who hasn't had a UTI, it is excruciatingly painful. Talk about needles. It is horrible, horrible experience. So if you're having recurrent UTIs, not even to mention the discomfort or pain, with your partner when being intimate, I mean, this is really horrible. So I think if you can have the risk of a UTI halved, then that is huge. That is really huge. And we should be talking about it. We really should be talking about it. So will that local application of, is that a estradiol cream? Mm-hmm. Will that sort out everything, or just the UTIs?
It will sort out, not for everybody, most people, it will sort out everything. It'll help the dryness. It'll help the elasticity of the tissue. It'll bring back lubrication. It can help with arousal. Now for some people, and maybe there's another thing called it hypoactive sexual desire disorder, basically low libido in addition to distress surrounding the low libido. And so that's a little bit separate just from kind of those local symptoms we were talking about. But for that, even for some women actually there's systemic testosterone that can be beneficial, but also local testosterone can actually, if a woman is still having symptoms with vaginal estrogen, if you apply testosterone vaginally, that can actually increase arousal and desire and orgasm quality as well. Because not only do we have estrogen receptors all throughout that area, we have androgen receptors in that area. So if someone is continuing to have pelvic pain, continuing to have decreased arousal, then that is another option to consider adding.
Oh, wow. Well, that makes so much sense because, we all think of menopause as being primarily this drop in estrogen, right? And then hormone replacement therapy, we're just thinking about estrogen. But I mean, my understanding is that testosterone also drops, even though relative to estrogen is not as big a drop, but it also drops in menopause. Is that correct?
It is, yeah, but so typically declines with age. Even before menopause hits, you'll start seeing a decline in testosterone levels. And this can also contribute to lower spontaneous desire, as well as reduced arousal intensity for some women.
Yeah, well, that makes so much sense. I mean, I see that Daniel in the comments section, hi Daniel, good to see you again. He's also drawing attention to the fact that testosterone plays a crucial role for women, especially during this perimenopause and menopause state, probably because they have less testosterone during this time. Could you maybe mention a little bit more about testosterone? Is it just locally that it needs to be considered? Because I think you mentioned you might want to be taking it, I don't know, systemically somehow to increase libido. Is that
Yeah,
true?
so it's only, and it's not in the United States, it's not actually FDA approved for hypoactive sexual desire disorder, although both the Menopause Society and the ISHWISH, which is a sexual health international society, recommend testosterone for that specifically. So that's the only specific indication it's recommended for. However, with that being said, testosterone, there's a great graph, but we have testosterone or androgen receptors literally all over our entire body. And so in someone who has a significant drop in testosterone, and especially, for example, women who have had their ovaries removed, ovaries even after menopause still produce 50% of our testosterone. So if a woman has her ovaries removed, especially when they're younger, they can have a precipitous drop in testosterone, and this can have a huge impact on quality of life. And so there's a great study that came out from, it's called Lewis Newson. She's News and Health in the UK, has just put a lot of great educational material out there for women's health. And they had over 1,000 women who were already on estrogen and progesterone therapy. And they added testosterone to the treatment protocol, systemic and transdermal, and we can talk about the dosing and route of that, but transdermally. And there was a 30% improvement in energy, 35% improvement in sleep quality, 45% improvement in mood, and 25% improvement in memory. You realize I didn't mention anything about libido there, and that's the only thing we're talking about testosterone for. And it's just so much more than a hormone that increases our desire.
Yeah, well, this is also then I want to kind of, seeing we're already in the HRT, hormone replacement therapy zone, let's kind of go with that. I know that a lot of people have got concerns. I think they're based around the Women's Health Initiative study, which showed a relative risk increase in, was it cancer? I think was it breast cancer?
Mm-hmm.
Yeah, of 26%, which implies a quarter more people, but it's not, because it was a relative risk. And if I remember correctly, the absolute increase in breast cancer risk with HRT was really like 1%, which means 1 in 100 women.
1,000. It was actually
1 in 1,000.
1 in 1,000.
Oh my gosh,
and
that's crazy.
Yeah,
so
and
we're avoiding it based on this trumped up charge that it increases breast cancer risk, even though it really sounds non-significant, or at least clinically unmeaningful.
100%. And we can dive a little bit deeper into that, because there's even more nuance in that study that has not been discussed. I just graduated from medical school less than 10 years ago, and I was taught in medical school basically that hormone therapy is dangerous. It increases breast cancer risk, increases stroke, cardiovascular risk, and even potentially dementia risk. And that was all from the Women's Health Initiative that was published originally in 2002. We are in 2025, and we are still stuck on the concerns of hormone safety due to a study from 23 years ago.
And I think the hormones at that time were different, right? And I think the route of administration was different as well.
Yep, exactly. And so that is very likely where that increased breast cancer risk actually came from. So If you look at the estrogen only arm, which is synthetic conjugated equine estrogen, so Premarin or horse urine is where the estrogens are extracted from. It actually, in that group, the follow-up, they had a decreased incidence and mortality from breast cancer in the estrogen only arm, which nobody talks about that. And estrogen has a black box warning about breast cancer, but there's, again, we kind of forget about that from the WHI. But in the combined arm, which was conjugated equine estrogens plus medroxyprogesterone acetate, which at the time was the most common synthetic progestin that was used, that was the one that had a 26% increased risk, or really 1 out of 1,000 increased risk of breast cancer. And now there have been several other studies that have shown these synthetic progestins do increase breast cancer risk. It's not huge, but time and again, the synthetic progestins increase breast cancer risk. Whereas
are there bioidentical versions of these hormones that people could take that don't come with those risks?
Exactly. Yep, there are, and they don't come with that risk. So there's been several studies now on micronized progesterone, and it does not increase breast cancer risk. When you look at bioidentical estradiol, does not increase breast cancer risk. And in fact, there's some studies in women who have had breast cancer and are on hormone therapy, and they have decreased mortality compared to women who are not on hormone therapy. Oh, wow. And that gets into a very tricky topic because that is still hotly debated. And so maybe we don't go down that path, but there's still a lot of conflict out there. There's just a big journal published last year in one of the largest oncology journals saying maybe we've got this idea on hormone therapy and breast cancer all wrong.
Wow. I mean, that's huge, because many women are choosing to struggle through the terrible symptoms, one of which is this sexual business we're talking about today. But I mean, all those other ones like heightened anxiety, insomnia, feeling like your body is not your own, your mind is not your own, brain fog, loss of memory, urinary tract infections, all those kind of hot flashes, hot sweats that drench your bed at night, irritability. I don't know. I don't want to go into all of those, but through all of that, where you feel like you're not even yourself, and it's based on science from more than 20 years ago, using very synthetic hormones, estrogen and progesterone, that were orally administered. Is that so? It was they were taken orally. Can you tell us about why that's important as well?
Yeah, so oral estrogen, whether it's Premarin, that's synthetic, or bioidentical oral estradiol, when it is metabolized by our liver, it increases clotting factors. And so that increase in clotting factors is going to increase your risk of blood clots. And so it's still not a huge absolute increased risk, even with Premarin. In that study, it was about 1.8 out of 1,000. But if you use transdermal estradiol, then that risk it doesn't exist actually. So if you have someone who has factor V Leiden, who is at significantly higher risk for blood clots due to a genetic condition, if you give them oral estrogen, then they have a 25 times higher risk of a blood clot. It's huge. Wow. If you give them transdermal estradiol, bioidentical, they do not have an increased risk of blood clots.
Wow. And they also have a reduced risk of getting or dying from breast cancer, not even an increased risk, because you're going with bioidentical. When you say transdermal, are you talking about the patch or a cream, or what form is this going through the skin?
Yeah, so the patches and creams are definitely the most common. There is also a ring that can be inserted every 3 months. Some women feel that it doesn't truly last 3 months, and that's typically more expensive, less insurance coverage. And so because it's meant to be every 3 months, if it runs out around 2 months, and then you're kind of stuck trying to figure out what to do in that last month with your hormones dropping again. So usually when I'm working with someone, we're typically going for the patches or the creams. The creams do have to be applied every day, whereas the patches you typically apply twice a week. There are some that you can apply once per week, but usually the twice per week helps with the leveling of keeping your hormones more level.
Okay. Wow. So that's a lot. Is it also, so you've mentioned we're doing transdermal, bioidentical estrogen and progesterone. Do you, as a standard of care, think that testosterone should be added to that mix? And also, I'm actually jumping the gun. I'm assuming you always do estrogen when people are deciding on hormone replacement therapy. If they're going to do hormone replacement therapy, you're doing estrogen because estrogen is the big one. It drops. We know progesterone drops as well. Do you only add progesterone when you're seeing symptoms of low progesterone, such as insomnia and anxiety, or do you do it across the board because it's low?
Yeah. So for most, if a woman still has a uterus, then she needs that progesterone to protect the uterine lining. So if you give unopposed estrogen and they have a uterus, then that uterine lining can just grow and grow and grow, and that can increase risk of endometrial cancer. And this, we actually saw this in studies before it was standard of care to use progesterone, that there was this increased endometrial cancer risk. And so always for a woman with a uterus. If a woman does not have a uterus, there is more flexibility, more kind of patient dependent what route we go, if we add in progesterone for a specific reason, or if we just see how they do on estradiol alone. There's been a lot of studies, and the standard of care actually, even from the Menopause Society, is if a woman does not have a uterus, then you do not use progesterone. And part of that is because the synthetic progestins negate some of the benefits of estrogen. And so the synthetic progestins that used to be mostly studied, they actually bind to androgen receptors. They bind to glucocorticoid, so our stress hormone, cortisol receptors. They bind to just numerous other receptors in our body. And so they increase inflammatory molecules. They increase clotting factors. They increase breast cancer. And so why would you want to use one of those medicines if you don't have to? But with the bioidentical progesterone, you may actually derive some additional benefit from using it. And so oftentimes in a woman who does not have a uterus, we may try to use it cyclically first to try to mimic what the body naturally does, which is once a woman ovulates halfway through the cycle, that's when progesterone levels really rise, and then they come back down when a woman starts her period, and then doesn't really have much progesterone around at all for 2 weeks. If for some reason they derive a ton, or maybe they derive a ton of benefit during using the progesterone, we may end up switching to using it continuously. There's evidence of benefits, like you mentioned, from sleep, some people for mood, from a bone health perspective, actually, which is not discussed as much, but it actually increases our bone density in addition to estradiol, which is very important for bone density. So it gets a little bit more nuanced, but definitely something I still consider even women who do not have a uterus.
That makes so much sense. But now you've got me thinking, right? Because you have your two phases. You have the follicular phase and you have the luteal phase. And the luteal phase is that half of the month after you've ovulated, right? Is that the luteal phase? That's what most women really don't look forward to, that phase. When progesterone goes pretty high, then estrogen goes lower, and you often feel definitely less amorous. I could definitely say that, right? So why would anyone want to do it cyclically? If you're now going through menopause, you have the choice to stay in the follicular phase as far as your body knows all the time. Isn't that great? It doesn't work like that, or am I imagining things?
No, I mean, some women, some of the things I've read say up to 30% of women in my practice, I have not seen that be the case, but that 30% of women do not like how they make progesterone, how it makes them feel. I'd say it's much lower. I've just had a handful of people that do notice negative mood changes from the progesterone, and sort of like, yeah, take it out if possible. If a woman still has a uterus progesterone, then you have to be more careful. It's not FDA approved, but there are transdermal routes of progesterone, and you can actually even apply it vaginally. But again, that's not FDA approved because there has not been adequate studies on how you can dose that effectively to provide uterine protection. So, but for many women, especially if sleep is a big issue, estrogen actually can really improve sleep quality, and it can greatly improve night sweats if that's what's impacting sleep quality. But for some people, they're still waking up 4 times per night or 5 times per night, and it's very disruptive. And the progesterone still can provide a lot of benefit for that.
Okay. And I must add that if you are highly, highly anxious, which is what happens to many people, and you're not sleeping, you're definitely not going to feel like sex, right?
Right.
So that's why I think people they don't really think about progesterone. They're like, oh well, progesterone is the hormone that isn't really involved in you feeling like sex, or even involved in all those things that you said you'd use estrogen locally for, right? For all the dryness and the, I don't know, collagen, everything else that you mentioned.
Yeah.
So you don't think of progesterone like that. But when you come to the psychological benefits, I think we mustn't overlook that, because if you really are exhausted and anxious and you're hating your husband, then you're really not going to want sex either. So I think those things are also something that we need to think about with this regard, which brings me to testosterone. Should that be always added because testosterone does increase libido? Or if we're thinking about sexual wellness and sex within, the menopause phase, where does testosterone fit in?
So if someone is dealing with hypoactive sexual desire disorder, they have that low libido, they're distressed by it, then definitely I'm thinking about testosterone, typically applied as a gel. 100%.
Only if estrogen alone is not working, or do you just do that?
If they are not having symptoms, or like they're on estrogen and they feel great, they're having good libido, they're having good relationships, then I'm not going to add it just to add it.
Okay.
But if they are symptomatic still, and usually
Okay.
I'll add estrogen first, just so if you respond negatively to something, you know
What it
is
is.
what it is. Yep. And so, and usually too, if someone, I'll give them 3 months on estrogen before adding in testosterone, because testosterone can downregulate estrogen receptors a little bit. So it just gives the body a chance to kind of readapt having hormones around. And so if at that point they're still symptomatic, then, and maybe for someone who's had their ovaries removed, we check a testosterone and it's on the floor, there's hardly any in the body, we're probably going to add it sooner than that. But if their testosterone's in the middle or low normal range, then maybe we do the 3 months of estrogen before adding in testosterone.
Okay. So it sounds to me like you are taking the blood concentrations, you're testing and treating and looking at symptoms. So it's kind of a combined kind of biochemical lab data combined with, are you having symptoms of that low hormone, before you work on the corrections, and you do one at a time, a bit like, as a dietitian, I always think, okay, an elimination diet, and then the re-addition phase, you always do it one at a time, because you've got to isolate what is causing what. It sounds very similar to me to that. Is that interpretation correct?
Yeah, yep, exactly. And say we check a testosterone level and maybe her levels are 40, 45, probably not going to start testosterone, maybe in rare circumstances, but that's a very good level of testosterone for a female. And so are they, going to get additional benefit if I bump their levels up? Maybe if I go higher than the normal premenopausal, it could still increase libido, but again, I'd probably be less likely to do that than compared to the postmenopausal woman I check and her levels are 20, or maybe her free testosterone is 0.5, which is, again, basically hardly anything there. Then I'm thinking she's more likely to really benefit from the addition of testosterone.
Okay. And here we're also talking oral route. Is that the same, like with progesterone?
So progesterone oral is the main method that is FDA approved. And just a caveat, the only version on the market, at least in the United States, it does have peanut oil in it. So people who have peanut allergies, you need to go to compounding pharmacies to get your progesterone. For testosterone, I typically go the transdermal route, because there's some studies showing oral testosterone also metabolized by the liver may impact liver function, just associated with slight increased risk that you don't really have to worry about with transdermal testosterone.
Okay, well, that's really, really good to know. I know that we're sticking on HRT a lot, everybody, and I realize that this isn't everything we want to cover, because there's so much we haven't covered yet, but I do want to just wrap it up, because I think this is so key to managing menopause for so many women, or perimenopause. And I mustn't just say menopause, because this is what I want to cover before we move on. And Daniel, again, has jumped the gun. Thank you, Daniel. He knows where we're going. Which is, if we refer back to the Women's Health Initiative, another thing, it wasn't just the route, or as you say in American, the route of administration, or the type, the synthetic hormones. It was also when they administered it. My understanding is that they took women in their 60s who had already very much postmenopausal, already had gone through all those horrible symptoms. Now their hormones are flatlined at wherever they flatlined. And these women will have already gained central adiposity by that stage. In other words, they will have that loss of shape, the loss of muscle mass, the fat gain, and potentially all the sexual symptoms that we've been talking about. By that stage already, it'll all be over and done with, as you mentioned, those ladies in their 60s, but yet it can still be salvaged at that phase. Daniel, and my question is, when is the best time to start looking at hormone replacement in women so that we can not only salvage their sex lives, but also just make them feel human and avoid these terrible side effects or effects of the menopause transition? When is the best time?
Yeah, earlier the better, based on the evidence. If you have a woman between the ages, even in the WHI, they looked at women between 50 to 59. They had, the average age was 63, so over 10 years post-menopause. But when you looked at that younger age group, they had decreased all-cause mortality, which there is no medicine you can give a woman that actually decreases all-cause mortality besides estradiol. There's been Cochrane reviews that showed decreased all-cause mortality is about a 6 per 1,000 women saved. And so, yeah, not huge numbers, but still, there's nothing else that can do that. And so during perimenopause, if someone is very symptomatic, then I would say start during perimenopause. There's no reason to wait. If someone is recently postmenopausal, again, you're going to get more benefit. There's evidence, it's called the timing hypothesis, but if you start hormone therapy before a woman has evidence of cardiovascular disease, before she has thickening of her carotid arteries or calcium on her heart arteries, that you can actually decrease progression or decrease risk of cardiovascular disease, decrease cardiovascular mortality. Once a woman has heart disease or has plaque on their neck arteries, you don't increase their risk with hormone therapy, but you no longer decrease their risk. It's just neutral. It's like a placebo. And so that's another area where I think the word or the education has gotten a little bit missed, because even in the Menopause Society, they actually say it's a contraindication to use hormone therapy if a woman has heart disease. But you look at all the randomized trials in women who have heart disease and you put them on hormone therapy, and they don't have an increased risk of another heart attack. They just don't have any benefits from it. And so I think that's something else that hopefully in the coming years will get acknowledged, that you're, from a heart disease perspective, you may not get benefit once it's there, but you are not hurting someone. And that means you can still benefit their hot flashes, their sexual health, and many other things they may be dealing with. There is evidence.
Sorry, I just wanted to make sure I'm understanding correctly. So with regards to timing, you're saying that you want to start at menopause at the very least, which is 12 months. It's difficult because you look retrospectively, right? Because menopause, for everyone out there, menopause is defined as 12 months or a year of not having a period. So you don't know when menopause is until you've ticked off those 12 months and you look back and you go, oh, okay, 12 months ago I went through menopause. So I'm just trying to figure out, so you say, obviously, when you have symptoms in perimenopause, so in any lead up where you're kind of, I imagine in your, now I'm thumb sucking here, my understanding, I'm imagining in the lead up, which could start 10 years, 5 years, 3 years before you're 50, 51, because I think that most menopause averages around the age of 50-ish. So I'm thinking if you start seeing symptoms in your 40s, especially later 40s, then you want to look into this. And then when you hit menopause, which is when you start not having a period, you kind of probably think you might end up ticking off those 12 months. Maybe that's a very good time to start. Is my interpretation correct?
Yeah. In the perimenopause, the menopausal transition, again, depending on how, if someone is having terrible hot flashes and they're in perimenopause, I'm not going to just leave them with terrible hot flashes. So we're going to treat them then. If they're in perimenopause and they're like, hey, I don't have any symptoms, I'm feeling great, I'm doing all these things, then we may not do anything. If someone is menopausal, and again, now one of the FDA indications of hormone therapy is preventing osteoporosis. So technically, because of that indication, every single woman can qualify for hormone therapy, because every single person could benefit from osteoporosis prevention. So there's, I have conversations with some people, especially if they have a family history of osteoporosis or a hip fracture. Even if they're asymptomatic, we may start them on hormone therapy because during those last 1 to 3 years before menopause, you lose about 2% of your bone density per year. And then across the whole menopause transition, you lose about 12% of your bone density. So there are instances, it's pretty significant. So we may, again, even in someone less symptomatic, consider doing hormone therapy for that protection. But otherwise, if you are less than 10 years post-menopause and you're less than 60, which again, is less than 60, I would still argue less than 10 years post-menopause instead of using age as a cutoff, because some women hit menopause at 55, then you are likely going to derive even greater benefit than someone who starts at more than 10 years post-menopausal. There's no longer you can't start it after 10 years, which used to be kind of a dogma. Don't start it after 10 years. And then also once you hit 65, you need to stop your hormone therapy. That has kind of gotten removed actually from the Menopause Society language, which is great. But you just may not get as much benefit if you do start it later.
Okay, that makes sense. So rather a little bit earlier than a little bit later. No one's going to know 3 years if you say start hormone replacement therapy 3 years before you hit menopause. No one really knows when they're going to hit menopause per se. So would you think it would be a good way to kind of look around at family members, maybe ask your mother when she went through menopause, your sister, your auntie, whoever it is, like ask them when they've gone through menopause. You can say, okay, well, everyone in my family seems to be going through menopause if they went through it naturally. I know many women, I do want to say for those people who don't know, and I'm sure everyone here watching knows that you can surgically go through menopause as well. By having everything taken out, by having a hysterectomy, then you've also just gone through menopause very abruptly. But I'm talking about people who go through it naturally. Look around, you say, okay, my sister, my mother, they all went through menopause, I don't know, at 51, because that's the average in the United States, if I remember correctly. Then you can say, okay, well, maybe when I'm about 48, and especially if, let's say, my mother has got osteoporosis or signs of osteopenia or whatever, weakened bone mineral density, lower bone mineral density, then maybe I should consider going on it at 48. Would that be kind of a good way of doing it?
I totally agree. And I think the other thing, bone density scans, at least here, we recommend getting them at the age of 65, unless there's several other risk factors. And I think that is way too late. I mean, you should be checking, I think, have a premenopausal baseline DEXA scan. And then during perimenopause or recently postmenopause, I think it is worth tracking that. Again, one out of 2 women will have a fracture related to osteoporosis. And so just screening at the age of 65, we are missing a big opportunity to try to prevent a lot of complications and issues that people deal with because of fractures from osteoporosis.
Absolutely. I mean, if it's you or the next woman, one of you is going to have a fracture. That's a very high risk. A very, very high risk.
Yeah.
Wow. Okay. I know we haven't got that much time left with you, about like less than 20 minutes, and we've got so much more to discuss. I feel I'm going to put a pin in that in the HRT, or obviously we can come back to it.
Yeah.
But I'm going to go back to, I think, what is called the genitourinary syndrome, which is what we were describing, right? When we were talking about the pain with intercourse, the dryness, the discomfort, the urinary tract infections. Is that what this genitourinary syndrome is? Is that right? Just so we get the terms right.
Yeah, exactly.
Okay, perfect. So we've spoken about that. But you did mention the pelvic floor. So the only reference I have to the pelvic floor is when I was pregnant, and they talk about, strengthen the pelvic floor and all that, especially after you've given natural birth as well. That's all I kind of know about that. And then there were these like exercises in these books where you had to like try and clench some muscle you didn't even know you had. Is that what you're talking about?
Yeah, exactly. So, and briefly before I expand on the pelvic floor, just when we think about genitourinary syndrome of menopause, I don't think I mentioned this, but over 50 million women deal with symptoms from it. 70% of women have bothersome symptoms from it. Only 25% of women will actually bring it up to their doctor. Again, partially because of embarrassment, partially thinking, well, this is just normal. It's aging. This is what happens. And then of those 25% that actually bring it up, only a total of 7% of women are getting treatment for it. And so it is so sad. And so this is something that all women should be screened for, because again, they may not want to bring it up. So everybody should be asked about it.
Absolutely.
Yeah. Yeah. It's something we can do such a better job at in medicine. So when it comes to the pelvic floor, we have several layers actually of pelvic floor muscles, and that is keeping everything where it needs to be. That is helping us. Actually, it's very involved in our sexual well-being. So the pelvic floor, the muscles being able to relax and tighten as needed for sexual activity is very important. And so you can actually have different pelvic disorders where there's pelvic pain during intimacy because the pelvic floor is way too tense. It is very tightened. And so it's high tone pelvic floor dysfunction. And so that can cause women to have significant symptoms. And so the pelvic floor also helps with our urinary, being able to avoid urinary incontinence, also helps with going number 2, having regular bowel movements. So about almost 10% of women will actually have some kind of incontinence, bowel incontinence, and even more will have some urinary incontinence symptoms. And 12% of women will end up having some kind of surgery for pelvic organ prolapse. And so it's a huge percent that will actually undergo surgery.
Wow, that's a lot. And again, no one talks about this. Like, I haven't heard this.
Yeah. It's not something that I was really even hardly discussed in residency or in medical school. It's a forgotten topic, although clearly a hugely important topic.
Yes. So this is a tightening of the pelvic floor muscles. I would have expected, okay, well, maybe it's, it's I don't know, less toned pelvic floor muscles, but you're saying it's the tightening. What causes that?
So it's actually both. So some people have high tone pelvic floor dysfunction and some have low tone pelvic floor dysfunction. And those two different things can cause a differing amount of symptoms. High tone, you may have more urinary urgency, like, oh my gosh, I got to go right now, right? Other low tone, you may end up having more incontinence, maybe more bowel incontinence as well, from not being able to tighten the pelvic floor when it's necessary. And both of them can lead to decreased satisfaction with sexual activity or pain with sexual activity. And so pelvic floor physical therapy is amazing. And there are studies showing 50 to 80% of improvement in pelvic pain in women who undergo pelvic floor physical therapy.
Oh my gosh, up to 80% improvement. Yeah. That is very, very promising. So is that something you go to a physiotherapist to learn to do exercises, or can you just look on YouTube?
You can, I think pregnancy and postpartum is one great YouTube channel that she does have a lot of good pelvic floor. I will say, just having been a woman who has had a natural vaginal delivery and some of the urinary symptoms and things that developed after that, I have done pelvic floor physical therapy. I have watched tons of YouTube videos, and having gone in person where they can teach you how to do those exercises is very different than just watching a video on it. You can get benefits from watching the video and trying at home, but it's to actually feel those muscles, which is very hard to feel those muscles and understand how to appropriately contract and appropriately relax them, can be very helpful to have a trained physical therapist in that process.
That makes so much sense. And is this something, having excessively tight or excessively loose pelvic floor muscles, is this associated with menopause, or?
It can definitely be exacerbated by menopause. And part of that is, again, we have estrogen, androgen receptors all over our pelvic floor muscles. So that's something else we don't think about, the fact that our muscles have estrogen receptors. And what happens when estrogen goes away? That's going to impact our ability to control that pelvic floor. And so, again, there's not enough research yet on this, but I've had women who have nocturia, meaning they have to wake up multiple times per night. They have urgency symptoms. They have an overactive bladder. You give them local vaginal estrogen, and those symptoms get better. And there's some with the urinary symptoms and evidence that does get better. But from specifically a pelvic floor muscular, there's not as much data. But when you talk to the pelvic floor physical therapist, you talk to OBGYNs that do surgeries for either lifting the bladder up or helping with pelvic organ prolapse, they're going to want all of those women on estrogen therapy to help decrease the chance of recurrence.
That is so interesting. So again, the hormone therapy can help combined with the exercises or physical therapy. That is really, really useful to know, because I think there are so many women, as you said, who struggle with urinary incontinence or fecal incontinence, or,
Yeah.
sexual issues around pain, sex. And I think this is really great to know that this is something you could get 80% improvement of people improve. It's
Yeah.
really, really big, and very, very hopeful to know that you can take the matters into your own hands with this. You can do the exercises yourself. It's empowering to know that. So thank you. I wanted to know about common female sexual disorders that happen during these times. We've spoken about the genitourinary syndrome. We've spoken about, just the hormones basically that cause
Mhm.
these physical changes, would cause unpleasantness during sex.
Yeah.
Um, are there any other female sexual disorders in midlife?
Yeah. So dyspareunia, which is really just a general term for pain with sexual activity, up to 44% of women deal with that. The hypoactive sexual desire disorder, up to 12% of women will have that. And honestly, I think that's probably even higher. We just don't screen for it very well. And then there's also sexual arousal disorder or sexual orgasmic disorder that affect 5 to 8% of women. And so that can be that the body just does not actually have the physiologic response or the psychological response to feel aroused or the ability to have an orgasm. And so with both of those disorders, you can get those things back actually. And it could be a combination, again, of hormone therapy, as well as there's actually cognitive behavioral therapy and sex therapy that can be very effective. And so if those two that I just mentioned is something that someone is really dealing with, then trying to find potentially a sex therapist that could really help them could have a huge impact on their quality of life.
Wow. So that now we're entering into a different territory. So
Mhm.
let's talk about that. Let's talk about the psychological realm of this. Because, you kind of think, okay, well, I was fine before menopause. Menopause happened, or before perimenopause, menopause, perimenopause, the menopause transition, whatever. It happened. And then, so there clearly it's a hormonal thing.
Mhm.
Why are we talking now about, surely if the hormones are right and your mind was right before, your mind's not going to be right now? Why do we need to consider the psychological aspect if the hormones have been corrected? Why do we need to go for cognitive behavioral therapy and sex therapy? Why?
So, sexual activity in general has a very large psychological component to it. Even in premenopausal women, there's a book that if someone wanted to go really dive deep into this topic, it's called Come As You Are. And basically talks about there are some people who just have spontaneous desire for sexual activity. And there are some people that, and in men, that's more common, but there are women that also have that. There are other people, and this is a larger proportion of women based on studies, that the right environment, the right moods, setting the scene, all of that has a very big role in actually increasing arousal. And so you can imagine if someone potentially has gone through the menopause transition, maybe they've had a loss of hormones, they've had pain with intercourse, where now when even the thought of that, their muscles start tightening up because their muscles remember, their body remembers the pain that was associated with it. Now it's harder for their body to get aroused. They're in their brain, they're thinking during the activity, they're like, oh, is this going to hurt? Is it going to be okay? It'll be over soon. So they're having all of these psychological thoughts. And so even once you give the hormones back, that if they had those things occurring during perimenopause or post, the hormones may help with the actual lubrication. It may help with the ability to become aroused, but that's not going to take away some of those thoughts that they were dealing with or some of the symptoms experienced. And so that's where, again, potentially cognitive behavioral therapy, sex therapy could really, really play a role.
Yeah, that makes so much sense. And I like that you've given us a resource to go to. The book's called Come As You Are. Have you got any other resources that women or their partners or both can go to figure out more kind of psychological support in this area?
See, I had it pulled up. One of the International Society for the Study of Women's Sexual Health, I think, is probably has a lot of resources available on their website. So I think that would be one place to go. The hopefully, and I know there's many doctors, again, because I was not trained in this, they're not going to be trained necessarily in this topic. But if you go to that website, that organization I just mentioned, or the Menopause Society, then you can find a directory of practitioners that are specifically trained. And so then that could be a useful resource. There's a website called Psychology Today that you can research people based on their specialty. So you could actually find therapists and see if there are therapists who specialize in this. And again, this is an area that people do specialize in because it's a very important topic for well-being, for quality of life. And so that I think just looking around for local resources, local therapists or local providers is an option. And now with telemedicine, you can oftentimes get a lot of the help that you need just through telemedicine. And so that's, again, when you go to those two websites, there's people all over the world, all over the United States that have now gotten additional training in this topic.
Oh, that's such a relief. It's so great that we're bringing awareness to this because people need to know where to go. And it's also really important that healthcare professionals, psychologists, doctors, are also becoming trained in this space and taking an interest in the space. Daniel says he's just got the book. Thanks.
Absolutely.
Yeah.
Yeah, it opened my eyes.
Very helpful.
Yeah.
So I wanted to ask about relationship things related to menopause, because I think relationships, I know that you're not a psychologist, but I'm sure it's all of this is so interwoven where the relationships often get negatively affected. What are you seeing in your patients with regards to their relationships with the menopause transition, and what can people do about it? What should people do about it?
Yeah, so it's very sad actually. There was a study, this was coming from a law firm, but it was a survey done on 1,000 women who were either had divorced or were going through divorces, and 70% of women reported that menopause had some role to play in their divorce. And that's another thing that I think is tragic. And because before the Women's Health Study Initiative, over 35% of women were on hormone therapy. After that study came out and another study shortly thereafter, less than 5% of women are currently on hormone therapy that qualify. And when you think that 70% of divorces are in part due to menopause, maybe not all of those are going to be prevented, right? But if you took 5% of women, even increase that up to 50%, I suspect a lot of those divorces may not actually have happened. And the reason is because, again, during that transition, the hormone fluctuations can cause drastic mood swings. Women can become very irritable. They can become very anxious, depressed. Over 50%, actually over 60% of women report brain fog and cognitive difficulties. And you can imagine if a woman is working a full-time job or maybe even a part-time job, maybe they're trying to take care of their mother or their father. They're balancing 5 different things, and now they feel like their brain does not function. They're more anxious for no reason. Now they're in a work meeting, and all of a sudden they have a hot flash. They're sweating profusely in the middle of a meeting. They can't control anything about that. And they get home from work, they're exhausted, and now maybe they're expected to cook dinner. How is that relationship? How are they going to feel supported in that environment? And it's just, it can be a setup for a disaster. And so you can see how that could so negatively impact a relationship. And then the other partner may not have, they can be supportive and loving and caring, but maybe they still can't take away the symptoms, right? They're not going to take away the night sweats where they can't sleep through the night. They're not going to be able to take away the irritability or the mood swings, even if they're sweet, if they do happen. And then, at some point, maybe it's harder for them to be sympathetic. It's been years and you're still dealing with these mood swings, and it's like, do something about it. But, they go to their doctor and they're offered an antidepressant that is not as effective as hormone therapy.
That's really, really sad, because they might have actually, it's different if they've been through a really not great marriage their whole life and the kids leave home and they're like, okay, well, now I'm finally going to break free. That's different.
Yeah, right.
I do think I'm sure that some of those menopause divorces are really probably just empty nest kind of, now I'm hypothesizing here, but maybe they wanted to get out of there a long time ago. Yeah. But I'm sure many of those are, as you say, directly linked to women feeling horrible in their lives and likely leaving. I know men could leave too, but it does look like the stats show that 80% of divorces are filed by women. I think if they're feeling so anxious and depressed, they're like, well, there's something wrong in my life. I'm not happy. I need to get out of this situation. And if
Yeah.
that is a hormonal, okay, I doubt it's just a hormonal thing, but if the hormones are exacerbating that or precipitating that, and that can be improved, corrected upon, and then maybe the couple can go for therapy or for help or work on their relationship or enjoy the time now that they're children out of the home. They could work on it because there aren't mood swings and there isn't anxiety and there isn't insomnia and there isn't depression. Then that would just be so much better. I think it's terrifying for the women going into menopause with regards to their relationship, and for the men, or for the women partners. It's very terrifying, but it's so nice to know that it doesn't have to be terrifying if you really can, with the help mainly of physiological treatment modalities like your hormone replacement therapies, locally, systemic, either dermal routes or whatever, combined with potentially psychological support help, books like the ones you suggested, organizations, websites like the ones you suggested, understanding doctors, practitioners who can help. I think that it makes it, and pelvic floor exercises, you're like, you know what? It doesn't have to be horrible. In fact, we could be like, you know what? I'm actually looking forward to this. I imagine myself, going into this last 40% of my life more like those amazing wise women in those fantasy novels, or in the Aboriginal Indian communities, where you're like, oh, I want to grow old like that. You can imagine if you rather grow older as a woman, not necessarily old, because when you go through menopause, you're not old. You're actually midlife. It's the new 50 really is the new 30, I think. But instead you're going into this transition as a beautiful cougar. It doesn't have to be what we all dread. And I think this message of hope for the women and their partners is so important. Thank you. I did want to just pop on another one of Daniel's questions. Daniel, I love how interactive you've been. Thank you. If anyone else does want to pop questions, and we actually are out of time, so after this one we're going to say take home messages and then say goodbye, because Dr. Laura has already given us so much of her time. But Daniel was mentioning about how you said that the psychological, basically the brain fog and all this cognitive issues that you can also have during menopause. He wants to know if you're then at higher risk of more serious cognitive issues later on in life, like I don't know, neurodegenerative diseases, Alzheimer's or other dementias. Are you at increased risk of that if you're starting with things like brain fog and cognitive difficulties, or not?
I have not seen that research. I know, and maybe that does exist, and I just have not read it. But what I have seen is if you start hormone therapy over the age of 65, or they looked at women over the age of 70 in one of the studies. If you start hormone therapy at that point, there was a 2.3 out of 1,000 increased risk of dementia. And again, this was not bioidentical hormones. That was not the kind that we were studying at the time. So maybe that risk totally goes away with bioidentical. We just don't have the studies for it. But if you start hormone therapy in younger women, 50 to 63, there is a study that showed the odds ratio is 0.35. Potentially you prevent more than 6 cases per 1,000 women of Alzheimer's or dementia. And so there's a great researcher, definitely recommend starting to look into her research, Lisa Mosconi, but she showed that during perimenopause and early postmenopause, women's brain actually has a 30% drop in glucose uptake. And that is significant. And it's actually similar to the pathology you see with Alzheimer's, where there's that decrease in glucose uptake. And that potentially, we don't know for sure, but there is now some evidence that can explain why so many women do experience brain fog, difficulty focusing, new ADHD type symptoms during menopause transition. And she actually has a great study, and they look at a 50-year-old who was perimenopausal, not on hormone therapy, a 50-year-old who was premenopausal, and then a menopausal woman on hormone therapy. So you had perimenopause or menopausal not on hormone therapy, one on hormone therapy, and then one premenopausal women. The woman on hormone therapy and the premenopausal women's brain scans looked the same. The woman who was in the transition off of hormone therapy showed the decreased glucose uptake in the brain. And so you can, it's very, and when you talk to patients, although the research is actually not very positive as far as cognitive benefits with hormone therapy, it just from the like mild brain fog symptoms women report, which is interesting because clinically, I have a lot of women now on hormone therapy, and almost across the board, there is improvement in their ADHD, in their brain fog, difficulty focusing. Like most of those symptoms, they like, oh, I feel like I'm back to myself. I can now calculate numbers again, where I was having difficulty looking at Excel sheets or reading books, was trying to remember what I had just read was more difficult. So those symptoms do seem to really get better with hormone therapy, even though research does not show great data, no harms, but just isn't shown a lot of benefit.
Well, that brings us to the whole insulin resistance thing. And I know we're now completely out of time. In fact, we're 5 minutes over, but if you can give us another maybe 3 minutes just to, as our closing question, let me just get rid of that question. Okay. Is insulin resistance, which makes me think, okay, yes, hormones obviously play, sex hormones now I'm talking about, play a role like estrogen in insulin sensitivity. But do you think that if that woman had gone, let's say, onto a ketogenic diet where ketones are supplying the brain with much of its fuel source, I think Buchanan et al. Show that about 80% of the brain can run, basically 80% of the brain's requirements can be met by ketones rather than glucose, even though it's known as a glucose eating engine, right? Yeah. What is your feeling about the role of nutrition? And I know Aman Singh is asking about physical activity or exercise. So I'm going to kind of put them together into one question, which is, what is the role of diet and exercise in the menopause transition? Can that help with all these symptoms we've been talking about, or is that just something to keep your bone mineral density and muscles good?
It can help. There's honestly not enough nutritional research studies that show specifically some dietary pattern, but talking to patients, and this is another interesting thing, there's the Menopause Society say, there are not specific food triggers to hot flashes. I have so many patients now that have told me when they have a sugar binge, or even not even a binge, just to have some sugar, that will end up triggering a hot flash compared to when they're eating strictly keto. Same thing with alcohol being a trigger for hot flashes. Some people notice spicy foods. So clearly there is an impact, even though the research may not show that yet. There is evidence that people who have elevated BMI, increased adiposity, do have more frequent and more severe hot flashes and night sweats. So likely they do have more insulin resistance, and the ketogenic diet could help alleviate those things. Again, has that been shown to decrease hot flashes? No, the studies haven't been done, but clinically we see that. There's other evidence showing that smoking, depression, anxiety, those things can actually increase hot flashes as well. The other symptoms associated with it, I think, honestly, many of those symptoms that are associated with menopause can get better, because we see in the literature that if you go on a ketogenic diet, you do have improvements in mood symptoms. And we see that a lot clinically, that people's depression and anxiety get better. With that being said, I have many patients who are very, very healthy, low carb advocates. They eat keto, they exercise regularly, and then they still have a lot of menopausal symptoms. So I think it can be beneficial and should not be neglected. And I always am emphasizing lifestyle changes and improving insulin sensitivity by far. We're talking about hormone therapy. We've already talked about that aspect of things. But for some people, regardless of if they're doing everything perfectly, they may still, whether it's genetics or something else, we're not sure entirely why, they may still deal with more menopausal symptoms.
Well, thank you so much. I think we could absolutely go into that for a whole nother hour, but I'm going to let you go because you've been so incredibly generous with your time and expertise, Dr. Buchanan. We are so thankful for you covering this very taboo, very topical discussion, which really isn't spoken about enough. As you said, what 7% of women end up getting treatment for these kind of things. I don't know, it was something like that.
Yeah, only 7%. Yep, get treated for GSM.
That's not fair. It's not right that so many women are suffering and under the misconception that they are at increased risk for things like breast cancer or cardiovascular disease, when in fact some of these treatments can help with those things rather than actually exacerbate them. So is there any last closing word you want to say to our audience before we say goodbye?
Yeah, I mean, I think it is just so important to make sure that you are your own advocate. If your doctor just poo-poos hormone therapy altogether, does not listen to your symptoms or address your concerns, or maybe they don't bring something up and you're too nervous to bring something up, find someone who can help you, because there is a lot that you actually can do, and there is a ton of benefits. I mentioned this in the very beginning, women in their 60s who have not been sexually active for 10 years, who are now very active and enjoying life with their significant other again. I've had several women who said their husbands have told me, "You gave me my wife back." And so it's pretty amazing to hear that, and just know there are a lot of things to try. It is not too late. So find the right team or the right person to get help.
Thank you. Thank you so much, Dr. Buchanan, for making people feel seen and validated and giving everyone hope and making people feel empowered to actually take this process into their own hands, be advocates for their own health, for their own sanity, and for their own relationship, and actually like go through this transition beautifully and peacefully and happily and enjoyably even, so thank you for giving us all that hope, and we really, really look forward to seeing you and your lecture in the training, in the menopause and perimenopause training. Really looking forward to that. Thank you so much. Awesome. And to our audience, sorry, go ahead.
No, just thank you so much for having me and really diving into this topic, because it is just so neglected, unfortunately.
Absolutely. And, I didn't even mention that the reason we're doing this topic, even though it actually isn't the topic of your lecture and the training, is because this week is World Sexual Health Week. And so this is actually in honor of that week. We felt, we really need to cover that. And so we were just so happy and honored. I am so happy that we got to cover this, because I think it is so important. And to our audience, I just want to thank you for joining us today, for joining the conversation. I see it was a lot of people watched this, and I know a lot more people watch after the fact as well. Happy Sexual Health Week to you. We wish you absolute, happiness with your sexual health, well into menopause and beyond. And we hope that you can share this with your sisters, with your friends, with your wives, with your husbands, and that it can benefit people around the globe as much as it has benefited me and our audience today. Also, for those of you who have not yet signed up for Nutrition Network's Perimenopause and Menopause course or training, which launches at the end of this month, please do. I think you will find the link in the comments section. Otherwise, you can also email support@nutrition-network.org to inquire about the training. And if you sign up before its launch date at the end of the month, you'll get the early bird special of 30% off. The course the training is designed for healthcare professionals and coaches, but it is also actually totally accessible and valuable to anyone who is interested in this transition, and anyone who knows anyone who is busy or in this menopause transition as well. So thank you all for listening, and it was great to see you today. Dr. Buchanan, was such an honor. Thank you. Thank you all. Good night, good afternoon, good morning, wherever you are. Bye.
Bye.